All right, today we're putting a really fascinating uropathogen under the microscope. We're going to look past the idea that Staphylococcus saprophyticus is just some random contaminant and really dig into its role as a highly specialized pathogen that, frankly, demands a microbiologist's keen eye. So, why all the focus on this one bug? Well, get this. Staphylococcus saprophyticus is the #2 cause of community-acquired UTIs in young, sexually active women. That is a massive clinical footprint, which makes getting the identification right absolutely crucial for proper patient care. And just a quick heads up, all of the information we're covering today comes from a comprehensive Gemini deep search. If you really want to get into the weeds and check out the primary literature, all the sources are listed in the notebook document for you. Okay, let's dive right in. To really get a handle on how Staphylococcus saprophyticus causes disease, we first have to appreciate its unique strategy for survival. This isn't a jack-of-all-trades pathogen. It's a specialist, a master of one very specific environment. Genomically, this organism made a really interesting evolutionary trait. It's coagulase-negative, which means it doesn't have that enzyme that clots blood plasma, a key weapon for its notorious cousin, Staphylococcus aureus. Instead of a huge arsenal of toxins, its genome is fine-tuned to be a urinary tract specialist. It's packed with genes for unique adhesion factors and a whole suite of transport systems that help it thrive in the, let's say, challenging environment of human urine. So let's head over to the bench. For us, clinical microbiologists, pinning down Staphylococcus saprophyticus relies on a pretty classic set of tests. And while these culture methods are still the gold standard, it's worth mentioning that molecular tools like real-time PCR or even sequencing are coming up for rapid detection. But for our purposes today, let's stick to the essential bench work. So, what are we going to see? Well, the profile is classic Staphylococcus. Under the microscope, you've got your gram-positive cocci in those telltale grape-like clusters. On a blood agar plate, you're looking for these really distinct, large, bright white colonies, and they are always non-hemolytic. It'll grow on mannitol salt agar and ferments the mannitol, turning that plate yellow. And the key biochemicals? Exactly what you'd expect. Catalase positive, coagulase negative, and, this is important, urease positive. Okay, now this next part is absolutely critical. This is a huge diagnostic pitfall. Unlike E. coli or most other common uropathogens, Staphylococcus saprophyticus is nitrate reductase negative. What does that mean? It means it can't turn nitrate into nitrate, and detecting nitrate is the whole point of a urine dipstick test. So if you have a symptomatic patient with a negative dipstick, you absolutely cannot rule out this bug. It makes urine culture truly indispensable. So this brings us to the money shot, the single most important test, Novobiocin. This is the cornerstone of its identification. Staphylococcus saprophyticus is intrinsically resistant to Novobiocin. This simple, reliable DIS test is what cleanly separates this true pathogen from common contaminants like Staphylococcus epidermidis, which is susceptible. If you see resistance, you've got your presumptive ID. It's that simple, that elegant. Okay, so we've got our ID locked down, but what does all of this actually mean for the patient? How do these lab findings translate to what's happening at the bedside? Let's connect those dots. Yeast pathogenesis is really a three-pronged attack. First, it uses these specialized proteins, adhesins like UFA and aureus, to just grab onto and stick to the cells lining the bladder. Second, its urease activity is a potent weapon. It breaks down urea into ammonia, which not only directly damages tissue, but it also raises the urine pH, creating the perfect conditions for struvite stones to form. And third, it's great at forming biofilms, especially on catheters, which makes it incredibly persistent and a real headache to treat. And all this leads to a pretty clear spectrum of disease. The classic presentation, of course, is uncomplicated cystitis, what's often called honeymoon cystitis. But don't underestimate this organism. It is fully capable of climbing up the urinary tract and causing much more serious infections, like pyelonephritis. And while it's rare, in patients who have some kind of obstruction or an indwelling device, it can cause life-threatening bacteremia and even endocarditis. All right, we've nailed the diagnosis. Now what? Time to talk treatment. And this is where things can get a little tricky because, as you'll see, different international guidelines offer slightly different roadmaps. Let's compare them. Let's look at the most common scenario, uncomplicated cystitis in adult women. You can see right away there's a fascinating split in approach. International guidelines, like those from IDSA and EAU, give clinicians a choice of first-line agents. But the Dutch NHG guideline is much more structured. It lays out a clear, tiered system. Nitrofurantoin is the #1 choice for 5 days. If that's not an option, you go to a single dose of phosphomycin and then trimethoprim. This really reflects a targeted strategy, probably based on local resistance data. Now, what happens when things get more serious, or when we're dealing with kids? Well, the approach gets more aggressive, as you'd expect. For adults hospitalized with pyelonephritis, the Dutch SWAB guideline recommends starting with IV therapy, like ceftriaxone. And it's a similar story for children with a febrile UTI, who need to be admitted. IV ceftriaxone is a standard first choice, with the dose, of course, carefully adjusted for weight. Okay, let's shift gears to what is, for us in the lab, probably the most nuanced and critical part of the job, susceptibility testing. This isn't just about reading an MIC. It's about understanding the clinical context and applying the right rules. This quote right here, it gets to the absolute heart of PK/PD, or pharmacokinetics and pharmacodynamics. The whole game is whether an antibiotic can reach a high enough concentration where the infection actually is. This principle is precisely why we have indication-specific breakpoints. So let's break down this EU-CAS table, because the devil is in the details here. The Cephextin screen helps us infer susceptibility to a whole class of beta-lactams. But look at the big three for UTIs: nitrofurantoin, fosfomycin, and trimethoprim. See that last column? It says uncomplicated UTI only. This is the key takeaway. These drugs concentrate beautifully in the bladder, making them fantastic for a simple cystitis. But for a systemic infection, they're basically useless. Reporting these results with that crucial context is one of our most important jobs. All right, to wrap things up, let's talk prevention. How do we stop these infections before they even start? The strategy really depends on where you are. Out in the community, it's really all about patient education. Things like adequate hydration, postcoital voiding, and sometimes even reviewing contraceptive choices. But inside the hospital, it's a completely different ballgame. There, the focus is all about preventing transmission with standard precautions and, most importantly, meticulous device management. That means aseptic technique for catheter insertion and getting those unnecessary catheters out as soon as possible. So, I want to leave you with a question to really chew on. Given that it can sneak past our rapid dipstick tests and that treating it correctly demands these very specific indication-based breakpoints, how does Staphylococcus saprophyticus force us to challenge our routine lab workflows and our hospital's stewardship programs? And that is our deep dive into the world of Staphylococcus saprophyticus. Hey, if you found this useful, please hit that subscribe button for more deep dives into clinical microbiology. And we would genuinely love to hear from you. Share your own experiences with this bug, your feedback, any questions you have down in the comments. Thanks so much for joining me.